Chapter Chapter 37. Chapter 37 covers the face, head, and neck trauma, and as well as brain trauma, so to a certain degree central nervous system trauma. And as with most of the traumatic injury things that we look at the AEMT level, the basics really still apply here. We look a little bit deeper into some of these different types of injuries, but for the most part, with the exception of maybe a little bit of IV fluids occasionally, or some possibly some analgesia, we're not going to do a whole heck of a lot more, again, at this level than we did at the EMT level. So, as with all the chapters, if you have not read and studied the chapter, do so at your earliest convenience. Simply watching and listening to this lecture is no replacement to studying it on your own. The same education standard applies, that we will apply fundamental knowledge to provide basic and selected advanced emergency care and transportation based on the assessment findings for an acutely injured patient. We have one multimedia video that was found on slide 42 regarding spinal injuries. Several objectives in this chapter, which you'll find scattered from 839 through 841 in your text. Alright, so as an advanced EMT, identifying traumatic brain injury by evaluating that mechanism of injury and assessing the signs and symptoms of injury can be a life-saving measure. By identifying them early, getting them transported to appropriate facilities quickly, we can have make a huge difference. And significant trauma to the face can include the airway, causing airway patency problems, which again can become a huge life threat. And we have to be sensitive to our patients and their ever-changing conditions. So as we're paying attention to how they worsen or how they may get better, that can be a huge indicator of how our treatment is actually working or not working for them. All right. Additionally, occasionally we're also asked some of the tough questions like, is this going to disfigure me? Is this going to scar me? Don't lie to them. Be tactful and supportive. Use statements like, we're going to do everything we can. The plastic surgery has come a long ways. Things like that. Injuries to the neck, especially the trachea or the larynx, can also be life-threatening due to an airway obstruction or the potential for them to pull an air embolus into their circulatory system. All right, so the skull obviously is part of the skeletal system. It is the major protection for our brain. We don't have a lot of other layers out there that really do much for us. Of course, you have the meninges, which are a little bit of a membrane protection on the inside of the skull. But on the outside, in most cases, we're talking just a few layers of skin and maybe just a little bit of fat is about all you have to protect on the outside. The skull is composed of two major components, the cranium and the facial bones. The cranium are the large plates that fuse together that surround the brain. Remember, the only major opening in the cranium is the foramen magnum, which is that large hole in the bottom of it the spinal cord comes out of. Then the facial bones typically are more irregularly shaped bones. Some of them are very delicate, things like the nasal bones and the vomer bone, which actually makes up part of the septum of your nose. Those are very, very thin, very, very small bones. We have the zygomatics, the mandible. Those are obviously a little heavier duty bones. Brain occupies 85% of the total space within the skull. You've got to understand that there are things like sinuses And then, of course, we have a little bit of opening around the brain to allow for cerebral spinal fluid to kind of circulate. The brain is not one solid complete mass. It's kind of sulci and gyri, which are the various grooves and ridges within the skull. And then you have places like where parts of our glands are, our ears, and so on and so forth. And the remainder is generally filled with cerebral spinal fluid and then the volume of blood. So as a cross-section of the brain, I mentioned some of the meninges. When we look at, starting at the top here, we have the cranium. The cranium is the bone, of course, so it's the bone of the skull. Directly below that is the dura mater. Dura mater stands for tough mother. That's what it actually translates into, is tough mother, and is a very tough outer layer that is intended to protect the brain. Below that is the arachnoid layer. There's the subarachnoid space between the arachnoid and the pia mater, and the subarachnoid space is kind of, well, the arachnoid layer is named as such because it kind of is cobwebby. It's very fluffy and open and allows for that cerebral spinal fluid to circulate around the brain. The pia mater itself is actually on the brain. It is that stands for soft mother, or translates into soft mother. And the pia mater is the outer covering of the brain, basically. So you have the cerebral cortex, the cerebellum, medulla oblongata, and then, of course, the spinal cord. So the brain is bathed in cerebral spinal fluid, which works as a cushion for the brain. It also serves it with nutrients. It has lots and lots of sugar in it. The old way of testing cerebral spinal fluid was actually to taste it, because cerebral spinal fluid would have a sugary sweet taste. That was about the only, sugar and water and oxygen are about all you find in it. It's surrounded by the three layers of the meninges. There are three significant parts of the brain, being the cerebrum, the cerebellum, and the brainstem. The majority of the brain is the cerebrum. The cerebellum is the little walnut-shaped looking thing on the backside, and of course the brainstem is that comes out of the base of the brain and then leads down into the spinal cord. The cerebrum is primarily responsible for our cognitive function, or our upper-level thinking abilities, our sensory functions such as sight, smell, taste, and touch, motor function, and emotion. Cerebellum is a coordination and equilibrium center, so it gives us our fine motor movements. So it gives us the abilities to do, to use tools with such precision. The brainstem is our vegetative function. That's what tells us when to breathe, tells our heart to beat, tells our blood pressure to rise and lower. So injury to the brainstem obviously can lead to loss of those vegetative functions and lead to death. Within the neck, we have really all vital structures. We have the larynx, the trachea, the esophagus. Now the esophagus we may not think is, well, that's not very vital. Well, you have to take in nutrients, and if you don't, within a very short period of time, you no longer exist. We have several major blood vessels transporting blood to and from the brain between the carotids, the vertebral arteries. So there's right there about 6 significant arteries that feed the brain. And then you have the jugular veins, internal and external jugular veins, as well as the vertebral, which bring the blood back from the brain and dump it into the superior vena cava. So any injury to that can lead to very significant bleeding. It can cause the patient to have very poor neurologic outcomes should they have injuries to that area. They simply cause some decrease in oxygen to the brain. Then, of course, we have the facial bones. The facial bones are really pretty much everything you see on here below the blue. And then, of course, you got kind of the tan and the green that's kind of representing other parts of the skull in the back there. But the orange and the pink and whatnot, those are all a variety of different facial bones. Between the nasal bones, the vomer, there's the lacrimal bone on the inside, zygomatic, which is the cheek, maxillary, which is your upper jaw, mandible is your lower jaw. It's showing you some nasal concha in there, which is actually part of your turbinates that helps to cause a little turbulence within your nose to heat and humidify air that you bring in. So we have 14 facial bones. The orbits are those that surround the eyes. So the orbits are actually composed of several bones. Most of our facial bones are removable with the exception of our mandible. And they provide protection for our eyes. Remember, our eyes sit back in those sockets. And then they form the framework for the face and the airway. Trauma to the face can cause significant brain injury. Things like the nose, all those bones around the nose are generally pretty delicate, and including the cribriform plate, which sits at the top of the nose that separates the nose from the cranium, is a perforated little bone that can easily be fractured because it's so delicate and perforated. So the anatomy of the eye, we kind of covered this in the medical emergencies portion, but we'll look at it again, where we have, of course, the lids of the eye. On the inside of those is the conjunctiva. We also have the cornea is what I was looking for. Cornea is kind of the outer clear covering of the eye. Beyond that, we have the iris, and the iris is the colored part of the eye that changes. We have the pupil, which is the opening within the iris, that then takes us to the lens, which focuses through the process of using the various suspensory ligaments to kind of change its size a little bit to help it focus. Light is then focused in on the back of the eye and the retina there, and where it starts to be encoded to be taken via nerves to the brain for interpretation. The sclera of the eye, which the sclera is kind of a tough outer coating of it as well. The anterior and posterior chambers of the eye. The anterior chambers hold the aqueous humor, and then the posterior chamber has the vitreous humor, which are the two different fluids that kind of are found within the jelly-like eye. So it's roughly a 1-inch globe. It is slightly, it's actually slightly off, slightly egg-shaped more than it is spherical. That outer layer of the sclera, clear covering in the front of the cornea, colored portion of the iris, that dilates and constricts, changes size to allow more or less light to come in. Typically, when we're in the dark, we have very, very dilated eyes. When we're in bright light, we have very, very constricted eyes. That lens changes size, like I said, a little bit, and it focuses light onto the retina. And then the retina is the light-sensitive extension of the optic nerve that takes that impulse to the brain. It actually crosses over at a portion of the midbrain and is interpreted on the other side. The two fluid-filled cavities that hold aqueous and vitreous humor, which kind of help give the eye some shape without tons and tons of extra weight. They are held in the orbits, which are those kind of cup-shaped bones, and the muscles. There's a variety of muscles that attach to the orbit and to the eyeball itself. to allow it to move. So we have some all around, top side, bottom side, each side, and some that are kind of diagonal as well. So that helps move the eye in various directions. All right. Patients with moderate and severe TBI can face years or months of rehabilitation and may have long-term or permanent disability. And TBI in patients who have sustained multi-system trauma contribute to nearly half of all trauma-related deaths. I think that just goes to show you just how important the care of the patient with brain injury can be. So, some signs, particularly of head and brain and potentially face and neck injuries, include altered mental status. You get your bell rung. Bleeding, substantial edema, discoloration. They have palpable fractures or crepitus. They may often complain of pain or swelling in the affected area, potentially loss of function, dizziness, headaches, nausea, vomiting. You need to do an adequate and thorough scene size-up to determine is the scene safe, and look for all mechanisms of injury. Remember that head injuries often can be extremely dramatic. Anywhere in which you grow hair, you have a lot of blood vessels, so therefore you're going to bleed a lot. So you may have a severe, what appears to be a severe bleed going on, but come to find out, you really look at it and it's a half-inch little cut on their head. So ensure that the ABCs are appropriate. Ventilate as necessary, oxygenation, push on the chest if you need to. Remember, swelling can be one of our biggest enemies when it comes to caring for head injury patients. And we can get severe swelling into the neck, into around the mouth and the tongue, the jaw. All those things can potentially lead to airway obstruction. In the worst case scenarios that involve airway issues, paramedics are probably going to need to intubate or perform a cricothyrotomy to cut a hole in their neck or put a catheter in their neck to ventilate the patient. So consider the need for ALS. It's not that ALS or not that paramedics have a lot of additional things that they can do. Sometimes they have one or two drugs that may be beneficial, and in most cases those are kind of last-ditch efforts. So they may have some things that might help, but for the most part it's really airway management that are going to benefit the patient. So if we have open wounds, use direct pressure to control bleeding. Be cautious, because if we have, say, depressed open skull fractures, it's possible that we put a little too much direct pressure on there and we're actually going to start poking stuff in on the brain tissue. Open wounds around the neck, keep in mind that it's possible that they could suck an air embolus in. If the patient's critical or has a substantial MOI, exposed, do the rapid trauma exam and a head to toe. In most cases, we're talking about a person with an altered mental status. They're probably not going to be able to give us the full scoop of what's going on with them anyway. And then we can focus exams for patients with very isolated injuries. Occasionally we get that, somebody who fell down and broke their jaw or something like that. So obtain our vital signs and a sample history when possible. Establish baseline for the patient's condition. Might include talking to people who know this person. So reassess on the 5 or 15 depending on their condition, and watch for signs and symptoms of shock. So again, we emphasize keeping our scene times down, that platinum 10 minutes. So we would like to have them into the trauma suite, into a surgeon within an hour. So keeping our time on scene short, getting them quickly assessed, managing any of those ABC items, packaged and moving down the road, and we'll consider doing the rest of the stuff on the way. That might mean starting an IV if we have time, if we have the hands, but we're we're going to do as much as we can on the road. All right, so let's talk about some specifics of injuries. Scalp injuries. These are very, very vascular, like I mentioned, and that minor laceration can bleed very profusely. When you have a person that has a little bit longer hair, that blood starts to mix with that hair, and it mats up, and it just creates a huge mess. And you're going to think, what in the world? And then, believe me, I've cleaned up enough of these scalp lacerations working in a hospital-based system that you almost chuckle when you actually get down to it and see what actually the patient has going on, because it's nothing. It's a little bit of nothing. So not to say that they won't have a severe bleed, but it's just going to, in many cases, look worse than it actually is. They can bleed very, very profusely, depending on what you get. I had a patient who tried to scalp himself, basically, in a vehicle accident, took off about a quarter of his scalp in this crash, and he had a pretty severe bleed, and it could have very easily become hypovolemic because he involved his temporal artery and was spraying blood out. So, and it can be an indication of a potential skull fracture and a TBI. It's hard for us to see in many cases, particularly if we have this bloody matted hair mess on top of their head. It's going to be more difficult for us to assess what truly is underneath that. So we're going to rely on other things such as Cushing's triad, or things like alterations in mental status that can help give us a better idea of what might be going on. So we're going to need to be very careful when we assess the bleeding. It's essential to control it, but we have to be careful that we're not pressing in on the skull. Large flap of scalp sometimes we'll have. Like I mentioned, the person who was in an accident and took off a pretty good chunk of their scalp. So the underlying tissue can then be a avulsed and almost hanging down, almost like a big giant floppy dog ear. Closed scalp injuries occur from blunt trauma. So sometimes the force itself will cause kind of a blowout, more or less, that will cause that tissue to split. May result in the formation of a hematoma. Seen some hematomas form under patients' scalps, which just end up being, you're pretty nervous because they're soft, they're squishy, but there's this giant bulging mass here coming off the side of their head, and you're not sure what's going on underneath it. Consider underlying skull injuries and brain injuries, and then application of cold pack may help reduce bleeding, certainly can help reduce swelling. Skull fractures. The different types of skull fractures that we may have the linear non-displaced, which is pretty simple. In many cases, that's what we're dealing with. Occasionally, we have depressed skull fracture, in which a portion of it has been punched out, more or less, and those fragments are pressing in on the brain tissue itself. We have open skull fracture, in which we might have a bit of the skull actually protruding out the scalp, or you can have, of course, an impaled object. So when we injure the skull, we have these thick plates of fused bone that provide protection for our brain. They typically will fracture with extremely forceful impacts, and in many cases it will cause some minor brain injury. It may cause major brain injury. But remember that there's very minimal separation between the brain itself and the skull. So any protrusion of the skull at all can be potentially damaging to the brain. Again, we focus on maintaining ABCs, and we're going to assess for traumatic brain injuries and cervical spine injuries. It's usually a pretty good rule of thumb to say if the patient has a skull injury or a skull fracture or a brain injury, that we should almost automatically assume that they have a cervical spine injury as well. Here's a video of a spinal injury. Watch that in the non-narrated PowerPoint. With linear skull fractures, we're talking about a simple thin line across a bone fracture on an x-ray. We're not going to have obvious deformity of the skull. We are probably not going to even be able to detect that there's a fracture in the field because it does require an x-ray. Depressed skull fracture, on the other hand, this impact has cracked multiple pieces, almost like a head hitting a windshield, that star or spiderweb pattern that you get there. And some of those parts and pieces are being compressed into actually the brain. It's parts of the skull being pressed into the brain, or at least up against the meninges. The closed skull fracture, the scalp remains intact, whereas an open, it's obviously flapped open. And if we have an impaled object, do not remove it. If we remove it, the chances of causing a significant brain injury or insult is huge. Now we may also have a basilar skull fracture, and when we're talking basilar skull fracture, think base. So the base of the skull, where the brain sits on, this is basilar skull fracture. So things like the cribriform plate and the very rough surface that the brain sits on in the bottom there. Typically things directly surrounding the eyes, the nose, and the ears, and associated structures have to do with the basilar skull. These are the ones in which we see clear or clearish bloody fluid draining from the ears, nose, or mouth, even sometimes from the eyes, for the patient with this head injury, and that's when we suspect that it's actually CSF. Cerebral spinal fluid should be clear, but usually because of the trauma, some blood has gotten free as well, so a little bit might mix. You can do what's called the target test. If you have some clear fluid coming out of the patient and you want to try it out, take a 4x4 and kind of basically put it into fold it up until you get a point right in the middle of the 4x4. So almost kind of try to make it into a cone shape, if you will, and touch that tip of that point into the cerebral spinal fluid or the fluid, and then open that 4x4 back up, and it usually will cause what's called the target test, in which you might have a faint pink ring, then you'll have a perfectly clear ring, and then another faint pink ring, and then a perfectly clear ring. That's usually a good test for cerebral spinal fluid. There's another trick to check for it. If you use a glucometer and get a little bit of that fluid into a glucometer, it will register a blood sugar. Remember that cerebral spinal fluid primarily is water and sugar, so it will come back as with a positive sugar. Two more common but late signs of basilar skull fractures include raccoon's eyes or periorbital ecchymosis, and Battle's signs, which is ecchymosis behind the ears. And remember, those are later signs, so we typically won't see those in the first 5, 10, 15, 20 minutes of a head injury. We're going to see those later down the road. All right, so we have to carefully assess the mechanism of injury and be aware that a patient who has sustained injuries to the head, face, or neck may also have other injuries, particularly of the spine. And then do not become too distracted and focus on the obvious injuries while others remain undetected. Remember, it's all about maintaining the ABCs. So when we're talking about traumatic brain injury, TBIs, the rigidity of the skull is a good thing for protecting it. However, it can be a double-edged sword if the brain needs to swell, but the the skull is not fractured, it can actually be the worst enemy of the brain, because there's nowhere for the brain to swell. There's nowhere for the brain to expand, because the skull, rightfully so, is a nice closed, hard system. Well, for the most part closed. There's a couple of small openings, but we don't have expansion joints in our brain or in our skull. So therefore, it confines how much the brain can swell, and therefore it increases the pressure on the brain. So we may have a primary brain injury, which would be the time of impact with the skull. Someone smacked in the head with a ball bat and causes some arteries to rupture, or causes some ischemia to form in parts of the brain. That would be the primary brain injury. We can have secondary brain injury. So people maybe who we were a cardiac arrest patient, and they laid there for a little too long before anybody started CPR. Those people can have that secondary brain injury, or an anoxic brain, basically. So cerebral edema and increased intracranial pressure. Our brain tissue is compressed by increasing ICP. So just like all your other tissues, they will swell when injured or ill. So, and as they swell, they eventually get to the point in which they no longer can swell outwards. They have to turn around and kind of swell inwards. So this is really kind of the same sort of thing that happens with, say, compartment syndrome or a pericardial tamponade, in which we've reached the limit of how far out we can go, but we're still continuing to swell. So any little bits of space that are left on the inside, now we're going to get compressed, compressed, compressed. And that may mean compressing some of the other tissues. One of the most common things that's seen with a brain insult is projectile vomiting. Now, somebody who falls down, bonks their head, pukes once, that's pretty normal. But people who have projectile and repetitive projectile vomiting, that should be a worrisome sign. So, your kid comes in the house from falling off their tricycle and immediately pukes, and then that's the end of it. It's probably not terribly worrisome as long as you're paying attention to the other neuroscience. But it's the repetitive and projectile vomiting that becomes an issue. Headaches, of course, and we may not be talking just headaches at the time of the incident. This can be headaches forever. There have been people who have developed migraine syndromes following head injuries. Additionally, we see things such as altered mental status. Now, that in and of itself doesn't mean that there's cerebral edema or ICP, but it should be strongly suggested that something's going on up there. Unequal pupils. Unequal pupils works when the bleed is on one side, and it's putting more pressure on one side of the brain than it is the other. We may also have Cushing's reflex, and Cushing's reflex is an increase in blood pressure, a decrease in heart rate. We also call it Cushing's triad, and Cushing's triad is the Cushing's reflex and the alteration of mental status, as well as erratic breathing. So we can have erratic breathing, increased blood pressure, decreased heart rate. We may have posturing, and when we take the Glasgow Coma scale, this is one of the things we're looking for. As we stimulate the person with a noxious or painful stimulus, they may do one of two things. They may do flexion, and actually with flexion, a lot of times they actually will even pull their chin in towards their chest there, their arms up towards their core, and that flexion posturing is also known as decorticate posturing. And then even worse than that is decerebrate posturing, or extension posturing, where their head extends back, their arms twist out and down. Those are usually both signs that they're beginning to herniate. So herniation is when the brainstem is being pushed out then through the foramen magnum. So signs of impending herniation: Cushing's triad, pupil changes, like they blow. Severe altered respirations, trismus or clenched jaw, posturing. So an increase in blood pressure will actually worsen intracranial bleeding and cerebral edema. So as blood pressures go up, 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 more blood gets pumped into the brain. The more blood that gets pumped into the brain, the harder it is for the body to keep it up. So in order to compensate, it says, hey, we need to continue to get blood to the brain, raise the blood pressure, and it's just an ugly catch-22. It can be decreased or corrected by decreasing the intracranial pressure with certain medications, in which most paramedics don't carry because they're kind of ugly, very touchy medications, and they're not always a lot of help. But surgery is what these people need most of the case. So we'll need to probably take them in, and they'll probably actually cut out what they call a window of skull. They'll probably keep it, maybe implant it in their abdomen so it continues to live. So they'll take out pieces of bone and allow the brain to kind of swell. Again, signs of herniation include Cushing's triad, pupillary changes, altered respiration, trismus, which is clenching of the jaw, and posturing. Not a good sign. We talked about decerebrate and decorticate. Flexion is decorticate. They flex it towards decor, and decerebrate is the other. So what other factors can worsen our cerebral edema and ischemia? Well, we throw things such as hypoxia, hypoperfusion, hypercapnia, hypocapnia, hypoglycemia, hyperglycemia, where we are taking those basic metabolic needs, those basic metabolic functions, and getting them outside their normal range. Now, sometimes we actually will, in this case, in the cases of intracranial pressure, actually it is okay to do some slight hyperventilation of our patient. And we do that in order to cause some vasoconstriction. What we're really aiming at is maintaining a mean arterial pressure that's enough to get a little bit of oxygen to the brain, but not so much that it continues to flood the brain with blood. So if the patient has a TBI, of course, they should receive some IV fluids, but we're going to ventilate that patient to remove excessive carbon dioxide. So with high PaCO2s, high oxygen or high levels of CO2 in the body causes vasodilation. Low levels of CO2 causes vasoconstriction. So if we bag them a little faster than normal, so instead of our once every 5 to 6 seconds, maybe we pick the rate up to about 20 a minute or so, or even maybe a little bit more, we can then start to constrict some of those blood vessels, which will slow down the amount of blood going to the brain. Why is it that we no longer give high flow oxygen to everybody? Because high levels of oxygen will also cause vasoconstriction. So high levels of oxygen or low levels of PaCO2 causes major vasoconstriction. So if we ventilate the hell out of a cardiac arrest patient and their PaO2 goes way up, blood vessels constrict and their brain starves. So some key components in our neuro exam, we're going to determine if the history of altered mental status or loss of consciousness after the injury. Good to know those things. Sometimes we just have to take a guess. Assess the level of consciousness, mental status, orientation. Check for pupils, make sure they're pearl, make sure they react, make sure they're equal. Look for any other neurologic deficits, CSM. Are we getting things out to the periphery? Look for, is there a difference between the legs and the arms? Is there the possibility that there's a spinal injury that's also causing some issues? consider restricting motion of the cervical spine. Basically, we're saying C-spine. We're going to do some C-spine immobilization, and then we're going to open the airway, ensure normal ventilation, oxygen, control bleeding, start an IV on the way if necessary, maintain a normal body temp. I mean, this is some basic stuff, but treating for shock helps treat the brain injury. Check their blood glucose. Check for any hypoglycemia. If they're hypoglycemic, we're going to want to cautiously give them a little bit of sugar. If we're suspecting that there's possibly a brain bleed, that the highly concentrated sugars can be detrimental. So we may cautiously give them a little bit of sugar slowly to kind of get their blood sugar levels up without causing damage to the brain, and then transport without delay. Furthermore, if we take a look on 847 in your textbook, it talks about ventilation. If we're able to monitor end-tidal CO2, we have capnography, we can actually gauge our ventilation on trying to keep the end-tidal between 30 and 35. Otherwise, very slightly elevating your ventilatory rate outside that 8 to 10 per minute, I'm sorry, 10 to 12 per minute that we normally would do, to up around 20 or so is usually a fairly good recommendation, although it's something you're going to need to check on what your protocol is. And this does change from time to time. Concussions. So when we're talking specific brain injuries, concussion, this is a brain injury caused by blunt force. There's really no structural damage. It can't be identified through imaging technology. So they're going to go in, they're going to do a CAT scan, and the CAT scan is going to come back negative. That's one of the ways that they identify that it is a concussion, because the brain doesn't look abnormal when they look at it on the scan. So there's not a severe physical macroscopic look. There's not a severe identifiable trauma. Yet we know that there are some small internal issues going on there. They may have a post-concussive syndrome, in which that patient starts to develop headaches, memory problems, depression. We know that over time, repetitive concussions can cause severe changes in the brain tissue, and they can occur in conjunction with other TBIs. Luckily, in many cases now with concussions, they're particularly in the schools, and I think a lot of the pro sports as well are looking, they're doing, in the contact sports particularly, they're doing testing on the athlete prior to the season even starting. So if something happens, they will test, they have their baseline results from the beginning of the season, and then if something happens, then they will test them again and see how they score. And the athletes will be retested ever so often to make sure, if they would have an injury, to make sure that they're suitable to return to play. I think we hear more and more stuff on this repetitive concussion syndromes out of particularly the NFL and even major leagues to some extent, and how they're having long-term effects. All right, patients may also have things such as retrograde amnesia. Retro is backwards, so they can't remember past events or facts. They may have antegrade amnesia, which would be forward, so things from the time of the incident forward. They remember everything up to the incident, but don't remember anything from the incident forward. So there's a couple different types of amnesia where they kind of have lost some of their memory. And then concussions can also lead to things such as a subdural hematoma. We're going to talk about some of those hematomas here in a minute. Cerebral contusion, so a bruise on your brain. So that may occur from the coup contra coup type injury. where the coup contra coup, the brain rocks back and forth. I think of it as brain whiplash. So the brain goes back and forth, and it damages the front of the brain. It damages the back of the brain. So it's from that rocking in there. There's that potential space that is not supposed to be there, but nonetheless crops up. So with our cerebral contusions, we usually will have some edema starting to form, as well as have some damage on the front and back of the skull. So it could be some visual problems, could be some emotional and sense of smell problems, because that's the two areas of the brain that are most commonly affected. Additionally, signs and symptoms that kind of go along with this: altered mental status, anywhere from confusion, unresponsiveness, can even become very angry or violent, weakness, altered respiratory status or pattern, bradycardia, hypertension, impaired speech, unusual behavior, unequal pupils, nausea, vomiting, seizures, posturing, and trismus. We've seen those before. It's good to remember. A DAI, a diffuse axonal injury, very commonly seen in shaken baby. And it is caused by shearing forces or tearing forces associated with the acceleration and deceleration. So this would be like super coup contra coup, where things that actually the brain has moved back and forth so much within the skull that things are starting to rip and tear. Prognosis is generally quite poor. Lateral impact motor vehicle collisions, this may happen in. It can happen really in any, but it's one of the more common times when you see that side-to-side acceleration and deceleration. So intracranial hemorrhages. Here we're looking at an epidural hematoma. Epi is above, dura would be, of course, the dura mater. So this is between the skull and the outer meninge, or the dura. There's blood now leaking between the two, and that blood is actually starting to now cause some extra pressure to form on the brain, of course. We may also have a subdural hematoma, and that subdural hematoma, we're now leaking between the dura mater and the brain itself. So in the either arachnoid space, usually between the arachnoid and the pia mater. Now with this, note that there are areas of sinuses and sulci in there, in which we have openings in the brain where extra blood can collect. It's a little easier for it to collect there. When we're talking specifically about these different types of injury, the dura mater, the subdural is usually the subdural is usually slower onset, where the epidural is usually quicker onset. Subdurals are usually a venous bleed, where epidurals in most cases are a arterial bleed. So we tend to see people progress much quicker with a epidural than we do with the subdural bleeds. Subdural hematomas often have affiliation or accompany other brain injuries, and they may have a very high mortality rate because a lot of times they're so delayed. People will be seen in a hospital and then will be dismissed. They'll go home and then just think, well, I've got a headache from this, getting bonked on the head, and don't think twice, and maybe they go and they decide, well, I'll go take some aspirin, or I'll take some ibuprofen, both of which thin the blood and kind of make the whole process worse. So they may decide to go lay down and just don't wake back up. Whereas people with the epidural bleeds typically have quick onset symptoms, and they know very quickly that something is wrong. We can also have an intracerebral bleed. And that intracerebral hemorrhage can be caused from lots of things. In many cases it is a penetrating trauma or a stroke. But blunt trauma can cause them. Blunt traumas tend to cause the epidurals or subdurals more commonly, but intracerebral bleeds, that's when we have a brain aneurysm style stroke, hemorrhagic stroke, is a intracerebral hemorrhage. So it's going to be really focal, and it'll be, what we'll see from those is really dependent on the place in which is primarily affected. So we have that bleeding in the cranial vault. I mentioned that epidural was between the skull and the dura mater. Subdural is between the dura mater and the arachnoid mater. We also have subarachnoid, which looks basically the same as the subdural, between the arachnoid and the pia mater, and intercerebral within the brain tissue itself. Facial injuries. Facial injuries, of course, are going to be very stressful for the patient. They know that their characteristic look is now endangered. It can cause, obviously, some issues with vision, particularly if we damage the orbit of the eye. The muscles of the eye or the tissues of the eye can catch on to some jagged bone edges. May lead to permanent disfigurement. It's not easy to hide scars on the face, so it can be particularly unnerving for patients. So you got to do your best to calm and comfort the patient, and remember our concern is that patient's airway and breathing, because that's the most common thing affected that could be life-threatening in the facial injury patient. We may have open wounds, we may have closed wounds. On this example would be probably some common, or would be some closed injuries that we would be concerned with. So when we have different classifications of certain types of fractures, Lefort 1, 2, and 3, if we have Lefort 1 fractures, we have really separation of the maxilla from the rest of the skull. A Lefort 2 fracture, we have separated the facial bones really off of the skull, lower down, basically across the bridge of the nose. And a Lefort 3 fracture is a complete craniofacial dissociation, where we've completely broken the face off of the skull, and it fractures through the orbits and way back on the maxilla, on the cheekbones and zygomatics, and has completely separated that off there. And you can actually take a hold with several of these fractures. Post-mortem, you could actually grab a hold and wiggle their face back and forth independently of their skull. So fractures of the face in general are going to be quite painful, particularly the mandible and the maxilla, both. But the mandible, there are so many muscles involved with that. It's kind of like a femur fracture, where you have so many muscles that are getting tensed up. And remember, inch for inch, the muscles in your mouth are probably some of the strongest muscles. You know, if we're talking pound for pound, they have some of the most remarkable strength of any muscles in your body. And of course, you can have some airway compromise. So Lefort 1, maxilla only, may have some slight instability and deformity. Lefort 2, the maxilla and the nasal bones. Lefort 3, the entire midface. And Lefort 2s and 3s will usually result in leakage of cerebrospinal fluid, because they've gotten up far enough into the cranial vault that it's now going to start to cause some instability between those basilar skull bones, and that's where that CSF starts to leak. Typically, fractures of the nasal bones are not life-threatening. They just are a little deforming, and in most cases they may cause, at best, maybe a little bit of a bloody nose, so we may have to ask them to continue to spit the blood out or have to suction them. But if we move a little further up and get into the orbits, or get into the zygomatic arches. The orbits are particularly concerning because of the potential for paralysis and damage of the eye and the globe itself. This is a penetrating trabet of the globe of the eye. I've actually gotten in there. You can see that the pupil is almost invisible due to some of the trauma and damage in there. So, of course, that's very concerning because damage to the eyes, you don't have a lot of chances to get those back. So. We've already kind of talked a little bit about some chemical exposure to the eyes. Obviously, the patients are going to be very freaked out about this. Anything that we can do to try to save a little bit of sight, we should really try to do. We also have weird things that will occasionally occur, like detached retinas. Detached retina can come from excessive amounts of force onto the eye, so say getting punched directly into the eyeball, or glaucoma sometimes. Spikes in certain intraocular pressures will cause detachment of that retina, which was going to cause them to have a loss of, kind of a quick loss of vision. Sometimes it's a very odd pattern of loss of vision. In some cases, we're talking really just an eyelid injury. Hopefully, that's the case, but that's still you're talking about areas that have significant amounts of blood vessels, and we have to be very cautious that we control bleeding, but yet still try to preserve any function and vision of the eye. If we have impaled objects in the eye, we're going to try to immobilize it as best as possible. Some bulky dressings around it. Remember, cover both eyes. Removal is going to cause additional injury, so cover both eyes. Remember, the eyes work together, so typically they go hand in hand. So if you leave the uninjured eye uncovered and they continue to move that eye around, they're moving the injured eye by proxy. Don't attempt to replace an eyeball that's popped out of the socket. If we have that, hold a cup and dressing in place while we apply the bandage. It circles the head and covers both eyes. It's important to cover the uninjured eye. If we have an eye that's protruding out of the socket, you can take a moist, sterile dressing, and this would be a case in which we want to be very careful to be sterile with our sterile saline, sterile dressings, and whatnot, and cover the eye so it doesn't dry out, and move them quickly to an appropriate facility where they can hopefully have that replaced. Example of chemical burns to the eye. Note he's got unequal pupils here. It's possible that the severe amount of damage that they did to the one eye with the chemical has done something to this. I would say more likely, since it was done in a clinical setting, they probably have dilated his eye with medication. So these chemical burns, of course, are big emergencies. They can cause blindness within seconds. Signs and symptoms include redness, cloudiness, swelling, blurred or diminished vision, pain, redness, and burning around the eyes. So if we encounter a patient with this, we're going to continue to flush the chemicals from their eyes with water for at least 20 minutes. If they have contact lenses in their eyes, attempt to get them removed quickly, because contact lenses are only going to trap chemicals underneath, and they're going to continue to cause burning. Some services carry little kits that have kind of basically little tiny suction cups on a little handle almost, that you can stick the suction cup in on top of the contact lens, and the suction cup will grab it and pull it out for you. But in a lot of cases, services aren't carrying those, so hopefully somebody's familiar with contact lenses and you can get that removed from their eye and continue to flush. Ear injuries. In most cases, we're really talking about external injuries that cause some bleeding and are really not a life threat. It's possible that the internal structures are affected. However, remember, they're all within the confines of the skull, and chances of those becoming injured are pretty slim. But an injury from penetrating trauma or a rapid change in pressure can even blow out the ear. They'll lose hearing, can have some bleeding from the ear afterwards. In most cases, it's really something that is really supportive care for us. A bull's teeth, you consider the teeth to be potential airway obstructions. Transport the teeth with the patient. Doctors may be able to reimplant them. Preferably, they have little kits that some services are carrying. That's an electrolyte solution that they will put the teeth in to help them stay in the most neutral environment possible, so that the possibility of reimplantation can happen. Otherwise, whole milk is a good option, but in most cases we don't have immediate access to that either. So just putting them in some sterile normal saline is probably what's going to happen in most cases. So we want to keep those moist. It's not like an amputation that we have to be worried about water is going to infuse these soft tissues, because we're talking a hard tissue here. So. All right, so what are the pertinent pieces of information gathered from the mechanism of injury? Well, we're looking for things such as the speed, looking at things such as the amount of force involved, was there losses of consciousness, so on and so forth. This one, oh yeah, this one actually goes back to your case study, so I'll let you re-look at that one. Neck injuries. In this case, we have laceration to the neck. One we want to be pretty concerned with because of the fact that not far from that same area, running right up along the side of the neck there, we have, of course, jugular veins and the carotid arteries. Now, if we hit a carotid artery, chances are pretty good that we'd see blood spurting out of there. But with the jugular veins, we wouldn't necessarily see that. And it's possible, remember, those jugular veins are going to feed right down to the superior vena cava, right back into the heart. And the possibility of sucking an air embolus in there is certainly something we want to be concerned with. Cervical spine injuries, of course, we want to protect the spinal cord. So all kinds of potential things that will cause this, and we know that in most cases it's going to be a blunt trauma. Remember, they are at risk for up to and including death. When you damage the cervical spine, the higher up you go, the greater chance of there being lasting, debilitating, or fatal injuries. So injury to the carotid artery, that's going to, number one, cause severe bleeding. Number two, going to cause a loss of oxygen flow to the brain. Swelling and hematomas from closed injuries in the neck can then, again, start to impede the airway. It swells inward as well as it swells outward, and it can start to cut off blood flow, or more or less give us a compartment syndrome to the brain. We have the potential for an air embolism to enter the neck, so it would be definitely something we want to consider putting an occlusive dressing over the top of. At the very minimum, put your gloved hand over it to keep any air out until you are able to put a formal occlusive dressing over the top of it. Injuries to the airway. So any injury to the trachea or the larynx is going to affect your airway patency. Usually they are very bloody, and in many cases you'll also have subcutaneous emphysema. Anytime you have injuries to the neck that allow air to leak into the neck, you have that chance of subcutaneous emphysema across the neck, the lower parts of the face, and the upper parts of the chest. And remember, that feels kind of like Rice Krispies underneath the skin, or bubble wrap underneath the skin. So you're going to frequently assess adequacy of the airway and breathing status. All right. So we're going to identify any life threats related to specific injuries, consider the potential for associated trauma to other parts of the body. Don't forget about the possibility of internal injuries that can cause severe internal bleeding and hypotension. And care for the patient with a head injury can be very challenging due to their altered level of status, which may also include combative patients. It's vital that we have additional help on scene and en route to the hospital. TBIs are very susceptible to deterioration of condition as a result of hypotension, hypoxia, hyper and hypocapnia. Ventilation, airway, breathing, circulation continue to be our primary concerns. High flow tube and positive pressure ventilation as needed. Remember, it may be beneficial in the patient who is experiencing some signs of a traumatic brain injury. Be prepared for suctioning and or vomiting of blood and whatnot in the airway. Failure to do so can lead to our loss of an airway. So again, not much new in the advanced world.